All right, everybody. I think we are going to get started. I'm starting to see the trickle of folks filing into the webinar here starting to slow. So again, really appreciate everybody joining today. My name is Andrew Spevacek. I am the VP of Strategic Partnerships and Business Development here at Well Health. I'm honored to be joined by my co-host, Lauren Brandon. She's the Director of Strategic Partnerships and Circulation and Logistic Care. Hey, Lauren.
Hey. Happy to be here. Thanks, everyone.
Awesome. And before we get into the conversation, I would like to take a minute to introduce our speakers for today, Dr. Sean Kelly and Dr. Monica Rivera. Sean practices medicine and teaches at Beth Israel Deaconess Medical Center. He is the Chief Medical Officer at Imprivata and serves as an advisor to Well. Sean's bringing a wealth of knowledge on clinical informatics and healthcare administration. Hey, Sean.
Hi there. Thanks, Andrew. Hi, everybody.
And alongside of Sean, we have Dr. Monica Rivera. Monica served as the Director of Clinical Services at Brigham Women's Hospital and Director of Partners Urgent Care. Monica is now the Vice President of Business Development and Sales for Circulation and Logistic Care. She brings an immense amount of experience on logistics and the continuum of care with both payers and providers. Hey, Monica.
Thank you, Andrew, and thank you, everyone, for joining.
So now, just to set the stage a little bit, I'd like to give some background on Well. Lauren will do the same on circulation. I think this will help frame the topic of conversation today and give everyone an understanding as to why leading health systems like Houston Methodist felt compelled to bring Well and circulation together to solve the problem that we're talking about today, really eliminating leakage through patient engagement. Again, here are our speakers for today, as well as my co-host, Lauren. So for us here at Well, we're in the market solving the problem of fragmented communications with patients. What you see on the slide is a common experience we feel for a patient today. The provider is vested in multiple patient-facing technologies, from self-scheduling to mobile bill pay to a portal to telehealth, and really each one of those technologies certainly drives significant value in and of itself, but without a unifying technology and strategy, the result is disparate, uncontrolled communications with the patient that result in lower engagement than what you really want and expect from the service that you want to provide to your patients. So Well took the stance of building a communication infrastructure that could unify the communications across those individual pieces of technology and improve engagement with patients across their care continuum, across their journey with their health system and with their provider. Well itself enables enterprise health systems and private practices, like I said, and vendors like Circulation to communicate with patients not only through a single channel, but across multiple modes of communication. We cover text message, email, phone, and live chat, all of which is built with the goal of creating a single stream, like I said, of interactions with the patient and a single source for health system staff to view all of those communications that are taking place with the patient. And in summary, really, for patients using Well, they receive all their healthcare communications from that trusted source from their provider. And Well really powers the representatives from our customers to seamlessly converse with patients in real time, ensuring patients are heard, have their problems resolved in real time, and drive staff efficiency, increase revenue. We're covering over 100 million communications per year, and really pride ourselves on the ability to help our health system customers deliver the right communication in the right context. I think one good example of that, sticking with Houston Methodist as a shared source between circulation, kind of bringing Well and circulation together. One of the first prompts that triggered Houston to bring Well and circulation together was the fact that Well is rolling out recall messaging, essentially prompting the patient to schedule recurring appointments based on information that Well is consuming from their EMR, in this case, Epic. As you can see, the results are super positive. We've achieved almost a 90% recall schedule rate after incorporating well to prompt the patient to schedule that appointment, that recurring appointment. And really what came to mind for the folks at Houston was if we're improving access to care by getting the appointment scheduled, what else can we do? What other technologies do we have in place that we can bring together to better improve the patient's access to care and ensure that once that appointment is scheduled, once the patient is leaving an inpatient encounter and has follow-up visits that they need to present for, how can we bring our other technologies together to better improve that experience for the patient? And I think that led really nicely into the relationship that Bell and Circulation has built and some of the results that Circulation as a product brings forward to a group like Houston Methodist. So with that, I will pass it over to Lauren after giving a little background on Circulation.
Hey, everyone. So thanks so much, Andrew. And it's funny because the Circulation story definitely started very similar to Well, but instead of communication, thinking about transportation and how it's always been a very disparate part of the health system. So there was a real need to digitize and kind of aggregate all of the different transportation supply being used by health systems. So Circulation was actually founded out of Boston Children's Hospital here in Boston to help improve emergency room discharge efficiency, and has kind of evolved to be a HIPAA compliant experience for transportation. So really tying in all of the different options available, tapping into rideshare, which provides immediate supply. It's something that in our on-demand environment is really, really useful, especially in healthcare, to get patients where they need to go and really provide a way to provide access and build upon some of the benefits that are already in place and get everything into one centralized technology. And so really kind of a similar situation when you think about the need as it relates to communication. There's also, a broad need within the health system space to bring transportation together and kind of coordinate that on a digital technology platform. So as you can see here, there's a number of different providers and users of the Circulation technology, tapping into all different types of demand. Or all different types of supply. So we have ride sharing services and then digital platforms where we can bring on additional levels of service, understanding that not all of the population is able to take a on-demand ride share trip. We also integrate with wheelchair accessible fleets, other types of transportation providers, and are able to tap into a lot of different resources to be able to manage that for the health system, provide a single source of invoicing, billing, and really just transparency as a part of a system that was never really regulated in the past. So we've seen a lot of savings, a lot of reduction in fraud, waste, and abuse overall by doing this. And then you can kind of see here just what the differences are between when you've managed transportation and when it's unmanaged. So really it does come down to lowering the total spend as well as improving member health outcomes. So if you're efficiently able to manage access and transportation and kind of leverage the different services available, ultimately the patient and the member are going to benefit, and then the health system is going to benefit as well. They're going to see reductions in no-shows and improved flow in their emergency rooms, improved outpatient follow-up, and working with companies like Well, we're able to kind of build upon some of those use cases and really ensure that there's success and transportation and all the other different digital technologies that are deployed within health systems are combined and aggregated and used in tandem. So happy to move on and talk a little bit more about some of the ways that we've done that. So this case study is actually for one of the Circulation clients that we have. It's an at-risk organization, so a provider group that's very vested in their patients and actually is held to a standard where if their patient gets admitted within a 30-day window, they get charged a pretty big fee. So knowing this and understanding, some of the different initiatives around post-discharge and engaging patients and getting them back in within that 30-day window, or actually this was within, I believe, a 4-day window to improve the overall readmission rates. We found that offering trips for the post-follow-up visit actually improved the readmission rate, and it fell from 18% in some cases to 9%. So saw a huge reduction in no-shows for that follow-up appointment, which thus results in healthier patients and a much better engagement process throughout the continuum outside of the emergency room, which we'll talk a little bit about here. So we are excited to share these statistics and work through it. And then in going back to Houston Methodist, which is our mutual partner here that suggested that circulation and well work together in the first place, saw an opportunity with 2 successful pilots going on this year to help improve patient access and engagement and solve a couple of different problems. One of the main problems being patient discharge and emergency room flow, and then going back to post-discharge protocol and improved patient engagement post-discharge. And so the solution was really implementing these 2 technologies, circulation to help improve the discharge flow, and then well to help with some of that proactive follow-up engagement post-discharge. So our vision in, working together is there's an opportunity to engage with the patients and make sure that not only are they getting efficiently discharged, but when they are discharged, what happens after that is a strategy that engages the patient, understands what their needs are. So if their needs do, relate back to access and needing to have a trip booked for them in order to continue going to those follow-up appointments to ensure follow-through, this would be a way to identify patients that might be eligible or may have a need for a ride. So it's a nice marriage of these 2 technologies and a great way to kind of show how there's an opportunity to build upon what's already in place to just improve overall engagement throughout.
So that's great, Lauren. Thank you. Maybe it's worthwhile just to take a little bit of a deep dive into some of these workflows, just because, as a practicing physician, there are a lot of big concepts here, and sometimes it's important just to remember some of the details that go into some of these workflows and just how difficult it can be to deliver high quality care, at a reasonable cost and in a reasonable time frame. There's always an access to care issue in healthcare, and we have a lot of caregivers that are very highly trained, very busy, very expensive, highly educated, and we really want to have them operating at the top of their license. And yet sometimes these workflows are so complex that, as you can imagine, they're dependent on so many multiple factors. And sometimes the silliest little things like transportation or lack of communication can actually cause major delays and major costs, even adverse events and errors, poor outcomes, decreased satisfaction, higher burnout rates for providers, loyalty issues for patients, safety, quality, all these issues. If you put yourself in my shoes as an ER doctor, for example, we talk a lot about overcrowding in the ER. And, Houston Methodist and others realized that a lot of the problems in the ER actually they're kind of linked to problems upstairs in the hospital. And trying to discharge patients from the hospital can be such a complex process in this day and age, especially when you think about, sometimes patients are going home, sometimes they're going to rehab centers, long-term care facilities, skilled nursing facilities, and all sorts of different areas across the continuum of care. And, sometimes discharges can be delayed for hours from something as simple as, the patient's family was supposed to pick the patient up and they didn't show up for an extra 3 hours. And suddenly that bed is occupied for an extra 3 hours. And therefore, there's a backup all the way through the system, and that overcrowded ER can't decompress. Sometimes, the decisions being made to discharge, and there's a lot of upstream and downstream effects on decision making. In other words, just the fact that if you have good communications with patients and you can get a referral appointment or a follow-up appointment, you may be able to discharge them sooner, either from the ER or from the hospital. And if you don't have those things, well, then you got to wait and kind of go back to square one and start to rearrange everything. And they may even cross over and stay an extra whole day in the hospital or more. And so, it's important just to remember that the patient flow and operations aspect of these patient care scenarios can really almost can overwhelm at times the provider aspect and the actual time that providers have to see their patients. One thing that Houston came looking for very simply was, you have this ironic situation. If you think about that primary care group that we showed the workflow for before, you have this issue of access to care where sometimes there's a backup of months where patients are waiting to see a provider, and yet statistically half of those patients don't show up for their appointments. And it's such a crazy scenario because you have all these providers ready to see patients and suddenly there's a no-show. Or on the converse side, you may have double bookings where you have providers that are so busy that they can hardly get through the patients. And, the complexity of care can be so great that you could make mistakes, you could have satisfaction issues. And so literally just messaging and making sure that a patient confirms an appointment and getting them transportation to that appointment can make the whole process really work much more smoothly.
Those are all great points, Sean. So I'll add a couple of things, and just to build on some of the things you raised and Andrew and Lauren raised as well. So you mentioned missed appointments. We know data shows that 25% of those missed appointments are in fact because patients couldn't get there due to a lack of transportation. So as health systems and as payers think of transportation, it's really not the end-all be-all. It's really a driver, a tactical driver to a larger strategic framework that our clients look for. The other thing that if you guys look at the continuum of care slide, you see all of these aggregate resources. So in many of these integrated care systems and many of these payers actually have the resources there in virtual urgent care, home care, acute care. What they are lacking is that connective tissue, if you will, to really bring all of these together. So the way we think of well and circulation is those are both the connective tissue that can really accompany the patient or the member across all of those care pieces and really bring everything together.
I love that idea. I was at a conference a couple of years ago where it was on quotes telemedicine, and one of the presenters said, "Do any of you telebank?" And there was like this awkward silence in the room because everyone was sort of like, "Well, what do you mean, right? Like I bank, and some of it's digital, some of it's in person, although precious little of that now. Well, it used to be in person a lot. Obviously healthcare is more complex than the financial services, but the point was a good one, right? Like it's not like telehealth is completely distinct from health, right? It's not like digital care is different from care that's delivered in person. In fact, one way to think about it is, digital tools are just more tools. Kind of like I have a stethoscope, I have my iPhone, and I have a laptop, and I have my tools. And from a patient perspective, think about, we're all patients, right? We're all consumers. There's certain things where I'd actually prefer to do it digitally, and granted, not everyone in the population is like that, but there's certainly enough of us out there and enough patients where that digital front door that we talk about, it's kind of an abstract concept until you make it real. And what I love about these technologies is it really makes that digital front door absolutely palpable and real, because to a patient, they can get things done, and they can get things done on their terms, how they want to do it, when they want to do it, and exactly the way they want to do it. And so, a lot of data shows a lot of people really do well when they have push notifications. Text messages is oftentimes the preferred way, and the systems can work through many different types of preferences for patients, but far and away, we all like to have health systems reach out to us in ways that are practical to us in the moment when we need them to make things happen that we need to happen.
Sean, and that's a great point. So just in terms of transportation, just as a bit of background for those of you guys that don't come from this world, this really started in 1965 when Medicaid and Medicare started adding it as a benefit. And really the reason they added it was because they identified it was a barrier to good healthcare. But to your point around the consumer-driven experience, traditionally the market has been led by brokers where you have to call a call center and they give you a 4 to 8 hour window, kind of like your cable installation, to just wait there at home to when you get picked up. So now you've essentially wasted or lost all day waiting for someone to pick you up to take you to a medical appointment. So that's not how we consume financial services, food delivery, regular transportation. And we think that the catching up, if you will, with these digital features and tools is very beneficial to the consumer.
Right, and I think, never has it been so important to use good consumer technology well, bad pun intended, although you did say transportation was a driver earlier.
I did.
I think it was an even better pun. I think it's never been more important than it is now. We have such a high pressured environment. I mean, every caregiver you talk to is overworked and overburdened with, administrative burden, and coordinating care is exceedingly difficult. Even within a system, in what you'd think would be the simplest cases, you look at this diagram, and it's actually enormously much more complex than this even. But let's take an example. Let's take someone with a knee injury, right? You get diagnosed with a knee injury. You might see someone in a clinic. You might actually, go to PT a couple times as an outpatient. Maybe you're non-weight bearing, so you have some issues. You need to arrange for transportation. And as Monica said, if you have a 4 hour window where some transport may or may not show up in order to go see an orthopedic physician who's she's gonna tell you whether you can go get your surgery or not, how can the system sustain that, right? It's insanity that we expect patients, doctors, and nurses to work under those conditions and actually, achieve things, whether that's in a fee-for-service world. Because either way, in the fee-for-service world, you don't show up for that appointment doesn't get revenue, and you're still paying the overhead of the patient and of the doctor and all the caregivers there. And in a value-based care system, same thing, right? The whole system's on the hook for preventing illness and disease, and there needs to be cost avoidance. So either way, you lose from a financial perspective. You certainly lose from a caregiving perspective. Maybe while I'm hobbling around, I fall and hit my head and sustain a worse injury. Maybe I get an infection because I'm sitting around all day. Complications can happen. And so even a simple case like just, getting your knee looked at, there's enormous complications and enormous implications for all the different lack of coordination if that happens. So, I think one of the things that we're all appreciating is that the distributed networks we all deal with are enormously complicated. And, we all talk about interoperability, but the reality is, in the world we live in, it's going to be a while before there's true interoperability. Look, we're all trying really hard with HIEs, and we're trying to not have information blocking. But we have to deal with the world we're dealing with right now. So what I love about technologies that are consumer grade are actually better. They're patient grade, right? They're actually almost better than consumer technology, is that they really allow key transactional workflows to happen in a seamless way and kind of in the now.
Yeah, no, and to build upon that and these use cases here and kind of tying it back to the overarching idea of avoiding readmissions and continuing to move people through this continuum of care, I want to highlight a use case that was actually recently studied here in Boston at Massachusetts General Hospital within their radiology department. So just a very practical application of using these types of digital technologies to really improve the flow of the clinic. So one way that the radiology department has been using transportation, and there's absolutely a way to tie communication into this as well, was understanding how to plan for surges in the clinic. So for example, if a patient needed to get in for some sort of imaging and had to be in that day, but the Mass General location was completely booked up and the patient was unable to get to any of the other in-network locations. So in this case, that would mean a 10 or a 15-minute Lyft trip if you were to take public transit, or if you were to find another way to get there, it would just be kind of a half. So what the clinic decided to do was kind of triage these patients and offer them a ride to keep them within their network, while also making sure that they receive the imaging that they needed that day, which ultimately helps the patient, get ahead of any findings that image would show, and keep them within the continuum as it relates to, the Massachusetts General Hospital network. So that's one way that we've seen this very practical application used in a way that's had tremendous success for the organization.
And just to build on what both of you guys are saying there is sometimes we have a hard time understanding, either as patients or providers or payers, how a member or a patient can or cannot get there because we miss out the social determinants of health piece. So many of these people are living with unemployment or addiction, or are in rural places. They don't have access to food. So again, going back to Lauren's example of MGH, many of these patients couldn't get to the appointment on time because they're working 2 jobs and don't have enough time to go to and from their 2 jobs and then the appointment. So that's something that needs to be addressed if you want to look at the clinical piece as well, and look at communication and transportation to really enable those social determinants of health.
Yeah, what I love about that example is it's so practical. It really does. It shows you how it's a win-win-win, right? The system is motivated because they want to distribute that care to the right resource at the right time in the right place. That's good for the hospital system. It's good for the provider system and the network as far as a cost and a revenue perspective. It's even better for the patient, right? Because like Monica's saying, this poor patient sitting there has all these concerns that we may or may not know about. To give them more options, to automate that, to allow artificial intelligence and a really robust automated system to integrate with scheduling systems across the network, the EHR, and then message that patient the way they want to be messaged in the now, and for them to be able to then quickly choose. Like, we can't predict for them what the best option is, but if we give them several options and they say, you know what, I don't mind getting to this other appointment, even though it's 15 miles away, right, especially if the healthcare system's actually going to get me that transportation. Right. And when you do the cost analysis, it's incredibly beneficial for the provider systems. But let's not forget the fact that it's incredibly beneficial for the patient and the family to actually get their study done when and how they want it, through whatever social determinants they have to battle through, and just to get their study done so they can move their care along one more step. So I love that example for all those reasons.
And I think there's a nice tie-in as well to managing the patient's referral process coming out of a discharge, knowing as the provider what that patient needs to go through to be able to consume the next step in care, tying both to the fact that well as consuming that information from the EMR, understanding when that referral has reached a point where say you've been discharged, you're referred to a specialist as a follow-up from your inpatient procedure, knowing when that is ready to be consumed by the patient, and presenting that to the patient in a way where they know that if transportation is a barrier to them getting that appointment booked and scheduled, that a service like circulation is available to them. I think that gets back, as we talked about before in the recall example, but providing the right content and the right context. And I think that's what's really powerful about the depth of integration that both circulation and well have. We know when the patient is ready to consume that service, and together we're better able to present that service at the right time.
Yeah, and Sean, I'd be curious to hear your experience as a practicing provider, right, as a practicing ED doc. So you're in one of the busiest emergency departments in the city of Boston. So what do you see in lack of fragmentation that actually happens? That we're not talking about it, but it just happens a day to day. So what do you see works well and what doesn't work well, and how can these tools improve that?
Yeah, I touched briefly on the fact that a lot of the decision-making effects actually go upstream and downstream just from the part of the workflow we're talking about. And what I mean by that, so again, put yourself in my shoes. I'm in the ER, it's 2 a.m., patients in front of us, and they have CHF, congestive heart failure. They were admitted recently. They're now back in front of us. I can think of two specific patients on the last shift. One fluid overloaded, so fluid on the lungs. Another one had a heart rhythm issue, tachycardia, atrial fibrillation, rapid ventricular response. So both patients are there in front of us with some complications of their underlying illness. We're caring for them. We're resolving the acute problems. We're, giving a number of medications. In one case, we cardiovert electrically. There are a number of factors in play of whether that patient is safe to be sent home or needs to be admitted. And you're at the crux of this decision-making process. And I got to tell you, a lot of what dictates what happens at that juncture in care in these high-stakes gambles are, is that patient safe to be discharged home? Do they have the referral coordination that they need? Is the discharge planning correct? And do they have access to the care they need to stay out of the hospital safely, not decompensate, get worse, and come back, or worse, get even sicker at home? And so that patient with fluid overload, once we get some of that fluid off and they're reasonably stable, if there's a system like well and circulation in place, and we know that patient can go home, sleep at home where there's less risk of infection, they can actually do better, they can get some rest, they can be monitored, and we know they have their cardiology CHF service appointment already on the books, or the messaging gets to them the way they need it to, in the language they need it to actually comply with it, and they have a ride to see Dr. So-and-so in 2 days, I'm going to be much more comfortable as an ER doc in good conscience sending that patient home, where I actually want them to go and their family wants them to go, if it's all tucked and tied and ready for them to succeed at home. Now, you take away those two simple factors, if we're not sure they can get back to their follow-up appointment, or if we just don't even know if we can get them one, because we're headed into a holiday weekend this week, right? I mean, there's so many practical considerations that pop up. It's the little things that get you. And just having this system in place is like a trust fabric. I can't quite describe to you what a difference it can make in the care decision-making process. But to have these things set up, knowing someone's got access and they've got good referrals and they've got a good care coordination, can make all the difference. Because otherwise, guess what I have to do? I readmit them. You can't send them home if you think they're going to decompensate.
No, those are great points. And just the other point that both of these tools provide, right, is the closed loop and the feedback. So besides booking the ride, besides communicating with the patient, you're actually able to see if the patient says, yes, I'll be there. You're actually able to see when the ride is dispatched to go and pick them up, or you're pinged if they didn't show up to the ride. So you're able to proactively manage that as a care coordination team versus see that patient at the ED 5 to 10 days later.
And then just thinking about it from the patient experience side as well, for me personally, knowing I was being discharged from something that traumatic and my caregiver was going out of their way to put all these tools in place to kind of put the white glove experience to the patient is something that as a consumer is so refreshing and effective and makes you want to continue going back for care. So it's one of those things where you tie in consumerization into healthcare and just taking that member experience and treating people differently and treating them, in a way that makes them want to get care and want to get better. And I think that if I were to be discharged and someone was to do all of that for me, I would be really happy. Thankfully, it hasn't happened to me recently, but
yeah, if you're going to care for the patient, you actually have to care about the patient. Right. And systems like this make a patient feel well cared for. The great part is we're sort of just scratching the surface about where this technology can go. And a lot of the use cases that are most well demonstrated right now are incredibly valuable, and they are taking care of these very logistical issues. But certain places have started to build even more logic into the system, and really, putting intelligence in there with AI and machine learning and automating it and scaling it up where you can touch so many patients so quickly, and the system can sniff out if someone's having trouble, right? If if the word shortness of breath or chest pain pops up, bang, it alerts right out, it turns red, it goes to human being, it says call 911, and a number of things can be triggered. And, the other really interesting piece of this is that because the technology is so robust in both well and circulation, there's a ton of data and analytics. And, parsing through that data and observing the effects and seeing the real, you talk about return on investment, but it's value, right? It's value. Just the tangible objective value is so high, never mind all the intangibles that, Lauren, you just spoke of, where, you engender patient loyalty and trust. You don't have leakage, you have keepage if patients feel like at any time, when they get text messages from the well system, it's from their doctor's office. Like, it's not from some random number they don't know that they think is a spammer and they ignore. And, it feels like very high touch concierge service at scale, which is, that's not easy to do, but, come on, like, there's consumer technology now that as a doctor, I really feel like we need to advocate more for our patients and ourselves, our caregiving selves, to force more of this high level technology into our system and use it to its utmost capability.
And I think that's one of the things, Sean, you mentioned before, being almost more advanced than your typical consumer technology. Patient technology needs to take it a step further. I think that outside of meeting the patient at the right mode of communication that they want, using that same contact point that they're familiar with, interacting with their provider, it really is dependent on those technologies being able to integrate effectively and to consume information from the EMR, to be able to integrate in the way that circulation and well are able to share information about where the patient is at in their journey, to really take that next step beyond just a consumerism tool to a patient as a consumer tool.
Yeah, and I think we should move to the Q&A portion, because I think there's a bunch of questions coming in, and the things we had planned on talking about, we'll address in the questions probably anyhow.
Yeah, so I'm looking at the questions that have come in. One of the ones that I'm reading is, what's one creative or tactical way you have seen your product used? So you guys hear us talking about getting the member or the patient to and from appointments. Some of our clients have really reinvented that paradigm and have said, well, does the patient really need to travel? Let's really use the resources to go to where the patient is at. So they've used these tools to really transport home health providers to the patient home. The interesting things, and again, we mentioned it at the start, no pun intended, is that it's really a strategic driver. So the way to think about it, it's not just about getting the provider from point A to point B. It's really around looking at provider productivity and looking at time of transportation, using that time in the car effectively to chart or call back patients or do other things. And then to really have an employee satisfaction tool for those employees that might not want to drive in the snow or don't want to park in the city, are afraid to be walking at night, that sort of thing. So those are the clients that just think about things a little differently. And then the other interesting use case is a group, a payer that is looking at the tool to really close gaps in care. So looking at their frequent flyers to the ED, their high utilizers, and really making a proactive outreach to them, saying, we can offer you a ride to this appointment or that appointment, but instead of really just offering it as a blanket, to offer it in a targeted basis. I don't know what your experience has been with Well.
Yeah, look, there are a number of different really cool implementations. I think one thing that I'm incredibly impressed with is just the language capability. So it's something, just knowing from our human interactions in the ER, when someone is not a native English speaker, it's really difficult, to give them the care and the respect that they deserve. And so one thing I love about the Well technology, I think it's 19 different languages or something. It can tell if someone's responding in a language. It can actually triage that out to the call center provider that's actually can speak that language. Or like, for example, I think one customer in California sends over 50% of their messages in Spanish, and you can take an automatic feed from the EHR on language preference, and the better other systems and technologies around Well get, the better the messaging gets. And I think that very first concept architectural diagram that was drawn and shows an amalgamation of all these different platforms integrating into that one unified communication layer and conduit is a good way to think about it. So that's one of the cool things I've heard about. Linking in, you had talked about, Monica, high cost and payer, just linking into copays and things. I think, and automating that process is another thing that has been done with the messaging with Well. And I think as the AI continues to be used more and more and gets trained up, we see places doing things like, encoding logic into responses where patients, as they start to say specific things that are medical, they can actually triage out to proper follow-up and get more and more advanced as they grow into that system. So we're very excited because we think the ingredients are there, the architecture is there, and really the sky's sort of the limit on what you can do with a lot of this. I mean, patients are sort of starved for it, right?
Yeah.
We're all kind of starved for just better communications.
And speaking of communication, one question that came in was, are you integrated into the EHR workflow? So can you talk a little bit about how you interface with the EHRs? And to your point about communication, does that trigger direct responses, or how does that kind of work?
Yeah, so as far as circulation, we are able to do APIs and single sign-on. Again, that's very client dependent. As all of you guys know, there's multiple different EHRs. So what we do with some clients is single sign-on when they're on Epic or Cerner or other EHRs, so that, again, the care coordinators don't have to navigate through different tools. We are working with multiple EHR vendors at this point to really kind of have that easy button from Staples, right? And that it is actually embedded at the EHR. Again, just circling back on what we said to start, the intention of this is not to make the job of a care coordinator or whoever is requesting this harder. And then the other component that we're really working on is, again, closing the loop. How do we use that data to inform clinical decisions?
So I'll start and I'll hand it off to Andrew when I get over my technical head. But, from what I've seen, absolutely Well integrates with EHRs, takes feeds from EHRs, oftentimes HL7s and whatnot, to get information like we just talked about, to book appointments. So integrate back into EHRs as well. I think one question from a technical standpoint, a lot of integrations are possible, already existent or underway. One thing we've seen with provider systems is it's a good chance to think about the processes and understand what do you want to put back into EHRs. You may not want an entire messaging workflow put back into an EHR, but you may want to be able to manually cut and paste some in, or you may actually automate certain aspects of that. And so we're seeing this as an evolving field. But I think one of the strengths of the Well platform, and it sounds like the circulation platform, is integration with the ecosystem around it, including EHRs, because that's one major source of information, both for input and output. Andrew, do you want to add to that?
Yeah, Sean, I think that's a perfect summary. And we've heard a few of the examples here. The way that I think about Well integrating with the EHR is that it's not just a tool to consume information and push content to the patient. It's a way to close the loop when that patient actually responds and interacts with that content. So think of the recalls example that we gave at the beginning of the presentation. It's one thing to ask the patient to actually schedule the appointment, but knowing when that scheduling has taken place so that we're not reaching out to the patient again, and we can actually close that loop in the EMR. That's taking it to the next step beyond pushing, like I said, content. Same with referral coordination. If we know that referral is ready to be scheduled, We know that a blocker to that patient scheduling that appointment is having transportation to that next encounter. Not only can pass along what it knows as a byproduct of integrating to the EMR, passing along that information to a product like circulation, so we can get that outstanding item closed for the patient, but we can also tell the EMR, hey, look, we've arranged transportation, and we will know from the EMR when that patient actually follows up and schedules that specific referral. So I think it really speaks to the fact that being two-way to the EMR, not just consuming information and pushing content, being able to close the loop is especially important.
Thank you, Andrew. So one of the other questions we got, really great question. How do we convince administrators and providers to invest in patient engagement? What I will say is you don't have to convince them. They are already convinced that good patient engagement will give them loyalty and provide leakage. What you have to work on is making sure that the tools you provide will further patient engagement. So in order to do those things, we, at both Well and Circulation, we think that you need to do a couple of things. One is really meet the consumer or the patient where they're at with digital tools where they can track, book, and really empower members. And the second piece is really, again, around closing the loop and seeing what the members and the patients are doing. So we have the case studies and the experience that really prove that ROI in terms of leakage or loss of leakage.
I have a ton of thoughts on this. So I find it fascinating. Patient engagement is such a big term that first you have to understand, what does a stakeholder really mean by patient engagement, right? And in some ways it's like a bunch of, blind men and an elephant, right? Like, does patient engagement to the patient access person mean the same thing to risk and compliance, to the patient engagement officer, to the chief of a department, to the patient themselves, to family? And so in some ways it's an unanswerable question until you figure out who's interested in what exactly they want out of it. And some of that, falls into some predictable patterns, but sometimes you just ask, or sometimes what you do is you actually don't try to push a new technology at a big problem that's fuzzy. You actually pull a technology into specific problem points or pain issues or areas that the hospital or the provider system's actively engaged in. And those fall into categories that are reasonably predictable, right? People want patients to be able to get to their appointments and have access to care. They want their patient satisfaction to go up. They want patient loyalty. They want higher revenue. They want lower costs. And so I think attaching it to ROI and metrics, the beauty of some of these newer technologies is the analytics are built right in. And so if you come at it with, let's go at risk together, and in the next 3 to 6 months, we're going to show you, just like those case studies that resonated, we're going to take your no-show rate and we're going to cut it in half. We're going to take your ROI, we're going to double it this way. So when you put numbers to it and you put specific goals, you can't do all patient engagement for all people all the time all at once. But you can certainly pick off several really, really important use cases and demonstrate traction. And oftentimes in the beginning, that's budget neutral because you have some other legacy technology doing things very poorly that you can just rip and replace. But then once it's in, patients love it, and then you can really, really start to grow it. That would be my technique is, a few early solid wins with demonstrated KPIs for certain stakeholders around specific aspects of patient engagement. One bite at a time.
That perfectly kind of goes into this next question here, which is what has been a successful way to reach post-hospital patients in order to get them scheduled with a provider in clinic? So talking about how do we engage with patients once they've left the hospital, which seems to be one of the overarching themes of avoiding readmissions and leakage and everything we've discussed today.
Yeah, I'll go back to the most simple use case. Just people want to be communicated with very directly in the way they want. A system like Well will communicate with them however they want to be communicated with. cell phone, email, call, but they almost all just want to text. So the simplest, easy way is you figure out which patients are most highly at risk and which ones you want to connect with the best. And you set up an automated feed from the EHR that, tries to get them to commit to an appointment and actually get a date and recalls them, just like the workflow we showed in the beginning. And you just set up that automated texting. And now if they have problems getting transport and they can't get there, then adding in the circulation piece of it could be priceless as well, because they might not be telling you why they're not committing to an appointment. But the ability to also then feed right back into the scheduling system, automatically have it look up and find the next 4 appointments if this one doesn't work for them, and offer it to them, like the MRI radiology study you talked about. Another great way to do it. So without going too far afield, text right away, and then automate it and give them options. And then if they commit to one, book it. Like send it right back in the system and book them, Dano, right then.
No, that's a great point. And we do the same thing at Circulation. So there's the opportunity to either use call centers or emails, or text. And obviously the preference is text. The very unique thing, and again, it goes around engagement and empowering the patient, is we have the capability to text a patient, and with clicking that link on a text, they can actually book the ride themselves. So that really speaks to the engagement piece. As far as how we've seen payers and providers do it, there's both the blanket approach and the target approach. So we're working with a couple of payers that really want to use transportation as an enabler to their clinical care. So they're sending mailers saying, heads up, this is within your benefit package. Call this number if you want to learn more. And then there's a targeted approach where payers or at-risk providers go to high utilizers or look at their clinics where they're having a ton of no-shows, or just their data around no-shows, and saying, all right, let's survey those members and understand where they're at. So going back to meet the patients where they're at, are they no-showing due to transportation? And then how do we catch them so they don't miss the next appointment?
And maybe I just want to clarify one thing. The technology needs to be really good, because if you're just robo-spamming people, we all hate that, right? Yeah. If you get some random number and you just get a bunch of gobbledygook, nobody wants that. Right. But if you have a system that's really adept, it's plugged into the EHR, into the appointmenting system, and it's if you have 1,000 patients that you've decided upon discharge are at high risk, you can now hit all of them all the time. And then if there becomes a communication loop where for some reason they can't pick an appointment and they start texting something that's free text that really, is just explaining something else, or they're schizophrenic or who knows, that can flag and go right to a human being, and a human being can get on the phone. And because you've now retasked those human being resources to more high level, they've got the time and the energy to actually respond to the high level issues where a patient really isn't able to just quickly text back and forth. So, and many times, a big deficit in the system is transportation. So that I think that is a valid, concern to address up front all the time.
Awesome. So we only have a few minutes left. So for anyone that had questions that came in that we did not have a chance to get time to answer, there is some contact information up. Please reach out to us directly. I'm more than happy, and I know Andrew is more than happy to answer your questions directly, but wanted to kind of just close everything up by hearing in your opinion, what can we do better as digital technology companies, as healthcare organizations, to bring all of these tools together and be effective and really at the end of the day, just impact patients in a positive way that trickles up to everyone.
Yeah, so from my perspective, there's an abundance of data everywhere, right? So big data is everywhere. And really the differentiator will not be big data, because that's everywhere. It's really the group that knows how to mine that data and understand the patterns and how you can use those data points to improve patient outcomes. So to me, that's one of the key pieces. And the other piece that we need to understand is consumers and patients are also flooded by that big data. So going back to what Sean was saying, it's really around meaningful interaction. So you only have a number of shots with the patient, As soon as you start what they perceive to be spamming or over communicating, you've lost them. So it's around how do you use that data in a meaningful way, and then how do you stage or really impact along meaningful interventions with the patient so that you can accompany them across the care continuum. Sean, would love to hear what you think about that.
Yeah, I mean, I totally agree. I think for me, it's all about partnership. This is an iterative process where technology companies really need to listen and be good partners with provider systems and healthcare systems, who in turn need to really listen to patients. And so you can't expect to, start some big project over the course of a year and never really check in on things, right? I mean, this is like, you have to be incredibly agile, and you have to really listen to patients. You need to act, but you also need to be sensitive to course correction. And so to me, this is all about picking off what the biggest pain points are for both the provider side and the patient side, and having the technology, take one cycle at that, but then very quickly course correct and say, okay, this part of it works great. We need to build more logic in here. We need to take this away here. We actually went too broadly here. We need to narrow this. And we see that all the time. Some of the most successful provider systems are the ones that have, regular cadence meetings. There's representation from all stakeholders, right? Within reason, right? Even with the patient somehow, if there's some way to understand, from patient advocacy, what's really successful and what's not successful. That's not always easy, but without that, I don't think there is success. It's partnership.
Perfect. Well, we are exactly at 2 p.m. if you're on the East Coast. If you're on the West Coast, it's still coffee time. But
Probably
Andrew,
still sunny too.
yeah, and Andrew's on the West Coast, so
Well, I appreciate that, everybody. Great conversation. And I think just tying it off, definitely reach out to us. Contact information is here. Happy to pull in Monica, Sean, Lauren, myself for follow-up questions after the webinar. We will be distributing information as a wrap-up here to everybody that attended. We also have some additional follow-up content, a little more detail on the way that Well and Circulation in particular are working together that we'll share with everybody that attended today. So appreciate everybody's time. Have a great rest of your day, a great holiday, and looking forward to chatting with you all more.
Thank you, everyone.
Awesome. Thanks so much, everyone.
Thank you.